falls down. So you may want to say his fall may be due to the medication, and it might not be due to the medication. It may be because he's hypoglycemic, he's hungry, and there may be many other reasons for it. So we describe this as an adverse drug event. Once you are not sure, you are suspicious, some other factors may be, causing this event. So we call it an adverse drug event. And we normally use adverse drug event when we are carrying out cohort event monitoring, or when we are carrying out active pharmacovigilance. So what's the difference between an adverse drug reaction and an adverse drug event? An adverse drug event is a type of an adverse drug reaction is a type of adverse drug event whose cause can be directly attributed to a drug and its physiologic properties. Whereas for an adverse drug event, it may not necessarily be attributed to a drug. A main distinction between an adverse drug reaction and adverse drug event is that an adverse drug reaction occurs despite appropriate prescribing and dosing. You're giving the right dose, right? Whereas an adverse drug event may also be associated with inappropriate use of the drug. So when it becomes an overdose, then it becomes an adverse drug event, no longer an adverse drug reaction. Remember, when we were defining an adverse drug reaction, we said it must be given in its correct dose. And if there's an event, if there's a reaction to it, then that becomes an adverse drug reaction. What is a side effect? This is an adverse drug reaction that is mild. I normally describe a side effect as a milder form of an adverse drug reaction. The WHO defines a side effect as any unintended effect of a pharmaceutical product at doses normally used in humans and which is related to the pharmacological properties of the drug. In other words, a side effect is simply an extension of the pharmacological properties of that drug, and in many cases is not harmful. Then what is a signal? A signal refers to reported information on a possible causal relationship between an adverse event and a drug. The relationship being unknown or incompletely documented previously. So in pharmacovigilance, when you say signal, what we mean is a new information about a drug that has not been reported before, has not been previously reported. Okay? That is what we call a signal. So usually, if you want to generate a signal, it's usually more than one report. You may have 3, 4, or more reports before you can say this is a signal. For example, somebody takes paracetamol and develops hypoglycemia. So ordinarily, paracetamol does not cause hypoglycemia. So we can ignore it, right? But if you now get another report of hypoglycemia from paracetamol, and another one from another health facility, and another one from another health facility, you're already getting 2 to 3 new information about paracetamol. Then it becomes a signal. Okay, and then that warrants further investigation. It warrants regulatory action. So the regulators will now need to write a Dear Healthcare Professional letter asking the healthcare provider to look out for such new information. Okay, and if they eventually encounter such information, they should report back to the regulatory authorities. So, and when we have 2, 3 more or more, it becomes a signal and warrants regulatory action. Now, what is evidence-based medicine? Evidence-based medicine is a systematic approach to healthcare. Okay, so it combines the best available research. So you are taking care of a patient, but you are using the best available evidence along with your clinical expertise. You're not looking at what your elders normally do. So you are prescribing based on evidence, based on the best available evidence, okay, with your clinical expertise to now take informed decision about the patient. And this pyramid is a popular pyramid that we use when we are talking about evidence-based medicine, because we want to look at which is the best form of evidence that we have. And you can see at the top of the pyramid is the meta-analysis and systematic reviews, because these are a collection of several other articles, several other research work. I now filtered information to really get, clear evidence, or you want to get a combined evidence. That is, you want to ensure that using all these articles, what will be the result when you combine these various articles. So that usually is the best form of evidence. However, we have the randomized controlled trials, and we have the cohort studies, that is the observational studies, which is also very, very good, very useful, especially for pharmacovigilance. And then you have case reports. Of course, these are weak evidence and background information. Now, what is the critical role of pharmacovigilance research on patient safety? Before I delve into the role of pharmacovigilance research on patient safety, let's look at the statistics on the screen. Class drug reactions are indeed a significant cause of death, ranking as the 4th to 6th leading cause of death in the US. This is the Lancet research work, okay? So it is telling us the impact of adverse drug reaction, patient safety. The other one says 1 in every 20 patients experience harm during treatment. They are supposed to get better during treatment, but it has been found that for every 20 patients, 1 of them experience harm. That is a complication or an adverse event or whatever it is, but it's harmful to the patient. That is fact. Again, look at the third statement. Above 50% of harm is preventable. And that is why research is very, very key. 50% of the harm experienced by patient is preventable. Half of this harm is attributable to medications. So we can actually avoid many of these complications due to medicines. And then look at the last point there. Common adverse events that may result in avoidable patient harm are medication errors, drug interactions, and so on and so forth. And the cost of this harm is enormous. And there are several research works that have delved into the cost of adverse drug reactions in terms of this treatment of the adverse event itself, in terms of the loss of man-hour, in terms of the length of hospital stay. All of this makes it a huge cost. So how do we reduce this? It's by research. So the pharmacovigilance research has a very critical role on patient safety. Now, moving forward, let's start from the foundation, the basics. You look at the randomized clinical trial, which looks at the life cycle of a medicine. And there are usually 4 phases after the preclinical phase. So you have the phase 1, looking at the safety. You have phase 2, which is expanded safety. In some cases, expanded, you call it safety and efficacy. And then you have phase 3, which is multi-centered, looking at both efficacy and safety. And then you have phase 4, that is after that drug has been approved by the national regulatory authorities. Then there is now continuous monitoring of that drug, okay, which is post-marketing surveillance. And that is where the pharmacovigilance research comes in. Now, Why is it that we have to continue with phase 4? Why do we have to continue with phase 4? That is the post-marketing surveillance. 3 critical reasons. 1, the number of patients is limited during clinical trials, and so rare adverse drug reactions may not be detected. And we shall give examples in subsequent slides. So you're not able to detect unknown adverse drug reaction. You're not able to detect rare adverse drug reactions during clinical trials, except the drug is approved and being used in the real world. Secondly, the duration is limited during clinical trials, and the possibility of missing adverse drug reactions that can develop after years of use is increased. So during clinical trials, you have few years to carry out your clinical trials. But in the real world, especially for chronic diseases, a patient can use antihypertensives for 10, 20 years, or antidiabetes, and so on and so forth. So during this period, the possibility of missing adverse drug reactions that were not captured during clinical trials will come up. Thirdly, special populations like children, elderly, pregnant or lactating mothers are not captured during clinical trials. We are just beginning to look at the possibility of clinical trials in children. So if this special population are not captured during clinical trials, you find out that in the real world, you have to continue with post-marketing surveillance to be able to capture the effect of these drugs in this special population. So the critical role of pharmacovigilance research on patient safety has to do with early detection of safety issues. Pharmacovigilance and research will help to identify potential safety issues early enough, and this will enable prompt action to protect our patients. Secondly, it helps to identify predisposing risk factors and possible mechanisms underlying the adverse drug reactions. Thirdly, it helps in informed decision-making. So you carry out your research and you're able to appreciate the problems, and then we're able to now communicate this to the healthcare providers and regulatory authorities, giving them accurate and timely information. Look at the example of the anti-malarials, that is the artemisinin combination therapies. Okay? At the time these drugs were introduced, we didn't have the safety profile of these anti-malarials with us, especially in the African setting. And so we had to carry out an extensive study, an active pharmacovigilance study called cohort event monitoring, to be able to profile the safety of these anti-malarials. We were able to come up with the safety profile and then the risk factors for the development of these adverse reactions. We're able to profile them. So this research impacts a lot on patient safety. And of course, it now helps in improving medication safety. You now are able to have safer treatments and finally enhance patient care. So patients now can use these medicines in a more rational way. They can advise the patients that these are the characteristics of these drugs. Beware, and this will lead to improved health outcomes. So these are some studies, some research work that has been done to buttress the first point, that is discovery of previously undetected adverse and beneficial effects of drugs. It's a study by Agu and Opara in 2013, titled Adverse Drug Reactions to Antiretroviral Therapy, Results from Spontaneous Reporting Systems in Nigeria. So these are studies done in Africa to buttress the key role that pharmacovigilance research plays on patient safety. The other one was a study that we did recently during the COVID-19 pandemic. And what did we do? We tried to monitor adverse events arising from the use of COVID-19 vaccines. So that it was an active pharmacovigilance study that we carried out in Nigeria, sponsored by the national regulatory authorities, NAFDAC, in collaboration with CDC and University of Maryland, Baltimore. And what was the objective? It was to do an active pharmacovigilance to look at the safety profile of COVID-19 vaccines in adults over the age of 18 for the purpose of identifying safety signals. The main finding was out of the 11,911 participants who consented and reached for follow-up, there was no vaccine-related mortality, and the studies confirmed that the vaccines were relatively safe. Another study was the one carried out by Awodele et al. In 2018, looking at the pattern of adverse drug reaction signals in NAFDAC pharmacovigilance database from January to June 2015. And then another one, yet in Nigeria, was adverse reactions to fluoroquinolones in the Nigerian population. We all know the problem with fluoroquinolones, especially in the younger ones. So we now decided to do a comprehensive study looking at the database, the National Pharmacovigilance Database, from 2024, from inception till 2016. And of course, we got very interesting results. Now, lastly, before I leave this aspect of the critical role pharmacovigilance research is playing on patient safety, is that the study by Ampadu et al. 2016 showed that the characteristics of the individual case safety reports from Africa are quite different from those of the rest of the world in terms of drug products and in terms of the types of adverse drug reactions that are reported. So if you look at the African database, African pharmacovigilance database, and you look at the diseases, what you find are infectious diseases, okay, like HIV/AIDS, like infections, okay? And so therefore, we're using more of antiretroviral drugs, which are using more of antimicrobials, antimalarials. It's against the rest of the world who are using antidepressants, statins, cardiovascular drugs, and analgesics. And so this also underscores the importance of generating our own data relevant for use in our own communities, in the African community. So we need to continue to generate our own African data on adverse events. Now, what are the gaps in adverse drug reaction reporting, translation, and implementation? I've been able to summarize these gaps into 3. 1, underreporting. Okay, into 4. The first one is underreporting. Underreporting is a key problem globally, but it's even worse in sub-Saharan Africa. Spontaneous adverse event reporting rates are lower in sub-Saharan Africa than in any other region of the world. And so there's a need for us to step up to find ways of increasing reporting rates in Africa. Secondly is limited awareness. And that's really underscores the very first point. Healthcare professionals have limited awareness of adverse event surveillance and reporting procedures. And so they don't report, apart from many other complaints, many other reasons, which a famous researcher called Ayman, which he captured as the sins of underreporting. The same thing applies with traditional medical practitioners. And you will agree with me that in this part of the world, or even globally, we use a lot of herbal medicines. And so the traditional medical practitioners did not even start it when it comes to pharmacovigilance. They have little knowledge, they don't practice it, and worst of all, they believe their herbals are even safe. And so there's even no need to monitor adverse drug reaction. This is a key gap when it comes to pharmacovigilance in Africa. Thirdly, regulatory frameworks are very weak or even not available in some African countries. So some countries lack legal frameworks for pharmacovigilance or have limited capacity. And lastly, the data quality. Ensuring data quality and accuracy is a significant challenge, it's a gap in the African setting. And so how do we now strengthen evidence-based pharmacovigilance research in Africa? We have to leverage on technology. We're in the world of artificial intelligence. We're in the world of machine learning. And so there are digital tools that abound that can help us to strengthen evidence-based pharmacovigilance research. So we have the MedSafety app, which is available on Play Store. So just if you don't have the app in your phone, just go to Play Store, download it. This is technology. And there are research work that has been done to actually show the importance of this tool, this very useful tool. And I will just elaborate on it in some of the slides, in subsequent slides. Then we have the electronic medical records. So these are tools, these are technological tools that helps to strengthen evidence-based pharmacovigilance research if we leverage on them. Collaboration, strengthening collaboration between stakeholders. We have stakeholders in academia, we have stakeholders in the regulatory sector, we have stakeholders in the pharmaceutical companies. By the time we collaborate, this has a great impact in strengthening evidence-based pharmacovigilance research. Capacity building is very key. Continuous training and retraining for our healthcare providers and also our regulatory staff. So this is the paper I was talking about to show the importance of the MedSafety app, okay, the benefits of the MedSafety app. And it's a recent paper, 2024, by Elemuwa et al. And this was a collaborative work by the regulators and those of us in academia. And even we even have people in the private sector coming together to do a proper research to really identify the benefits of the MedSafety app. So it was carried out as a retrospective study, looking at what was the data before the introduction of the MedSafety app, and then what was the data or the trend after the introduction of the MedSafety app. So 6 months before and 6 months after. And then we now compared the effects, and this is quite interesting. So following the deployment of the MedSafety app, the National Pharmacovigilance Center recorded an increase in the total number of adverse events reported received from VigiFlow from 2,000 in the baseline period, that is before, to 18,000 plus, okay, in the 6 months after the introduction of the MedSafety app, which signals about 81% increase. Secondly, there was a reduction in the proportion of paper-based reporting. So people were now going to the apps rather than using the individual case safety reports yellow form. And this reduced from 98% to about 15% post-deployment. And lastly, which is also very, very key, was many patients, many consumers were now reporting directly making use of the MedSafety app. And this increased from about 2.7% to about 17%, showing the benefits of the MedSafety app. The electronic medical records, like we said, will be very useful for pharmacoepidemiological studies. And that is where we are now in this part of the world. How do we ensure that we're able to link up the electronic medical records in various healthcare facilities so that we can have big data, we can have large data, and we can carry out useful cohort studies, useful observational studies, okay, that will help us to appreciate the relationships between exposure and outcome and help the regulators to make informed decisions. So this is another important need for evidence-based research, but we have to get this EMR right. We must be able to have a uniform link between our EMRs such that we'll be able to harness the data together. In conclusion, while challenges persist, progress is being made in strengthening pharmacovigilance systems in Africa. Continued efforts are needed to improve evidence-based medicine research and pharmacovigilance, and this will ensure the safe and effective use of medicines for African populations. Thank you very much for listening, and I'll be happy to answer your questions.
Thank you, Professor Oriagba, for that presentation. I think all participants kindly note down your questions. I think we are going to take all the questions at the end for all the presenters, so that we can save some time. Please note it down. And then we thank you very much for that very insightful presentation. And please kindly wait behind so that we can take your questions in about 30 or 40 minutes time. I think we'll go on now to the next presenter because I want the flow to be logical. So I'll go on to Dr. Oluchi Mbamalo, so that she can talk to us about patient and public involvement in pharmacovigilance, why it matters, and so that it can follow logically what Professor Oriagba has just presented to us, and then the understanding will be better. I don't know if Dr. Oluchi is on.
Thank you,
Okay.
Prof. Fadari.
I can see you. Good. So you have the floor.
My connection, it looks a bit unsteady. So I've got two devices. I just want to know which one will not let me down. Sorry. Just a moment. Can you see my screen?
Yes, we can.
Yes, I can see from here.
Thank you. Okay. Thank you, Prof. Fadari. And thank you, Prof. Oriagba, for that very interesting and insightful presentation. There are so many things that we know about pharmacovigilance, but every time you listen to lectures, you learn a bit more every single time. So I'm going to speak into the role of the patient and the public in pharmacovigilance and what patients and the public can do to assist us with data. And so when I look at this, we define pharmacovigilance so that we know what you're talking about. The prof has already done that for me. I just want to, in addition to what he had said, we all here, or many of us here, know that medicines and vaccines have kind of transformed the landscape and the treatment of disease. And they proffer many benefits. And so those vaccines, we can prevent many infectious diseases. Because of medicines, we can manage and control some conditions. But in addition to these, like Prof. also have side effects.
I think we lost temporarily. Just a minute, please. I think she got logged out, so hopefully she will connect in uh, another minute or so.
Sorry, can you hear me?
Yes, we can now.
Okay, my apologies. I think I'm going to keep my video off.
Okay.
I thought it could carry the video, but I think it could have been part of what caused this.
Okay, you can also share your slides. So we share from this side if it would help.
Yes, if you can allow me, please. It says the host has disabled sharing.
Okay, you can go now.
Thank you. Can you see my screen?
It's starting to show. Yeah. There now.
Right. Okay. I think you may have lost me from the first slide. I just want to. But I'll keep my video off. Please, hopefully that will help. So we're looking at, thanks, Steve. We're looking at the roles that patients and the public can play in pharmacovigilance. And that's what I will present on to add on to Prof. Oriagwa's wonderful presentation. And so when we look at patients and carers, we are thinking of the role that they can play in pharmacovigilance because their input assists a lot in the data that we get. And like I mentioned earlier before the network was cut off, I'm not sure if you heard that, but I was talking about the advantages that we have now with vaccines and medicines and how they have transformed the landscape for treatment and healthcare. But how, in addition to that, there are also some adverse reactions to some medicines, which are meant to treat and heal the patient, and which we need to understand so that we can then minimize risks for other patients and make sure that all patients get the best of the treatments that we are giving them. Like Prof mentioned also, a lot of these are preventable. And if we have data on how these can occur or the risk factors that can predispose to this, then we know better how to, look after our patients better. And so prevent adverse reactions or side effects that we can actually prevent. So when we look at the life cycle of a drug, like Prof mentioned, it has different phases. Prof has mentioned the 4 phases that are involved in drug research. But before this, we have the basic research, where scientists identify the drug or a potential agent that has drug activity. And once this has been identified, the drug progresses through the clinical trials that Prof has actually described to us. In phase 4, which is the post-marketing approval, this is where we have, like Prof mentioned, a lot of members of the population now taking the drug. In the clinical trial settings, phase 1, phase 2, phase 3, as we go down the phases, the numbers increase, but this number is never the same as the number of people who will use it after the drug has been approved. And so in that post-approval phase, we now get into what we call phase 4 trials, which is where our pharmacovigilance also comes in. And we're looking at how this drug is used in different populations and the effects that they have in those different populations. So I do not want to repeat what Prof has said already. I just want to highlight that ongoing, pharmacovigilance, ongoing awareness, ongoing caution to the effect of drugs and the counter effects are very, very important in continued patient safety. And this continues even after the drug has been released, even after it has been approved. and there is no time that it stops, no matter how shortly or how much longer the drug has been in the market. And so we need reports at various stages of drug development and at various stages when the patients use the medicines. And patients can actually do this by telling us about side effects and adverse reactions they have to a particular medicine. What this actually helps us to do is then collect the data that we require. Like Prof mentioned, there is now a wider population of people who are using the medicines compared to what we had in clinical trials. And so there is now a greater chance to pick up something that may have been missed during the clinical trials. Because you now have a larger population that is exposed to the same agents, and this population has some differences. So you can now start picking up, okay, maybe in the clinical trial, there were 2 or 3 people who have a particular characteristic, but in the wider population, you have like 20 or 30 of those people. And maybe that characteristic predisposes them to a particular reaction drug. Now, when you have 2 compared to 3 people, to see this effect in the population. This highlights the very, very important role that I'm so sorry. I'm next to my router. I'm not sure why the disconnection is still happening. Hello, can you hear me?
Yeah, we can hear you.
Yes, I can hear you from here.
I'm so sorry. I'm not sure why my screen keeps going off. Can I share once again? Or do we move on to someone else?
Hi, Oluchi.
Hi, can you hear me?
Yes, we can. I think you should just hurry up, like to the patient part, since your network is unstable, right? So we can move on to the next presenter.
Okay. Right. Okay. Thank you so much. Thank you. And so I was saying, thank you so much. And so patient reporting extends to the medicines that they have used. And patients, because they are the subjects of care, they are the recipients of medicines. And so they can provide the data that we actually need for pharmacovigilance studies by telling us how they feel about medicine. If there is an untoward effect that they have experienced, it would be helpful if they share with their provider, or also try to report that to the national.
I'm sorry, colleagues. I think our colleague is having network problems, so I think we may have to move to the next presenter, and it will give us some time to finish up. I think after. I'm not sure if I think so. I think we'll call on Dr. Uche Elemora if she's on the call. I think she's there. I can see her. So that she can take her presentation, and she's going to tell us about the role of NAFDAC in pharmacovigilance in Nigeria. Pharmacist Uche, you're welcome. You have the floor.
So good evening, everybody. I am happy to be here for this webinar. Just like the presenter said, I will be taking us through the rules of NAFDAC and pharmacovigilance. So, my presentation will simply be on the overview of pharmacovigilance in Nigeria. What exactly do we do? Prof, thank you so much for your presentation. And Pharmology, thank you so much, because I believe that all we're doing here is to create the awareness in pharmacovigilance, which is what every professional needs to know, because pharmacovigilance, as we know, is our collective responsibility. Both the healthcare workers, the patients, the public, caregivers, and everybody. So pharmacovigilance simply is all our collective responsibility. So for the purpose of this presentation, we'll just look at a brief history. I'm sure we all know what's the legal framework and the basis for the PV. Sorry, I'm not putting on my camera because it may interfere with my network. Are you seeing my slides?
Yes, I can
Hello.
see.
Yeah, we can see. We can see.
Okay. So we look at the structure of the PV system in Nigeria, what the scope is, what are the methods of our reporting, and the key challenges and achievements we have done in Nigeria on pharmacovigilance. So by way of a history, we all know that the saga for pharmacovigilance started way back in the 60s, when we had the thalidomide problem, pregnant women taking the thalidomide for early morning sickness. And the implication was that there was occurrence of a rare adverse events, adverse drug reactions that were not established during the clinical trial phase for the use of the medicines. And the world paid so dearly for that mistake, because it resulted in the giving birth of phocomelic babies, children without hands and limbs. And this stimulated the establishment of pharmacovigilance worldwide by WHO. And countries became members of the global program, the WHO Program for International Drug Safety Monitoring, which Nigeria became the 74th member in September 2004. Since then, the story of pharmacovigilance has increased, and it continues to increase globally because the awareness of the need for people to pay more vigilance to issues of drug use, prescriptions to patients because of a lot of confounders that we see in our practices. And our system, we all know, is fraught with polypharmacy. So a lot of concomitant drug-drug interactions, drug-food interactions, and so many things are happening, and that we healthcare professionals must pay due diligence to the outcome of every treatment process. So patient safety must be at the center of every treatment process and at the center of every healthcare provider, because the patients are the reason we are in business, per se, in quotes, that we have a profession that we need to defend. So it is our ethical responsibilities to our patients to continuously increase the awareness of pharmacovigilance. A lot of people have defined pharmacovigilance, just like the WHO simply puts it, is the science and activities relating to detection, assessment, understanding, and prevention. So when you look at these key 4 components, you must detect the safety concern. There is need for an assessment. After the assessment, if we have an understanding of the predisposing risk factors associated with that drug event reaction, it helps us to prevent further occurrence in our patients. So drug reaction, pharmacovigilance encompasses not only adverse drug reactions, but any other drug-related problems, such as issues of drug abuse, misuse. When people misuse, a doctor says take 1 tablet 3 times a day, because of poor knowledge, awareness, and a lot of personal decisions. We misuse a lot of medications. You see people begin to take tramadol and all sorts of medications just to make them high, drug abuse. So all these problems, issues of medication errors, lack of efficacy, and even counterfeits are things that we should continuously pay attention when we are treating our patients and in order to improve patient safety in Nigeria. So pharmacovigilance activities are coordinated by the National Pharmacovigilance Center, which is situated in NAFDAC. And we know that the simple reason is that since the regulator is the one that gives approvals for medicines, safety is a mandate by the government, federal government, under our act, to ensure the safety of medicines and other regulated products. So pharmacovigilance obviously has to be situated there so that any informed regulatory decisions can be made based on safety monitorings and data that we have, evidence-based data, which will help the regulator make informed regulatory decision. So the MPC serves as a hub for reported adverse drug reactions and adverse events following immunizations from the health workers and the public. So we have the the national database, which is also linked to the global database. And this helps us to collaborate with countries, other regulatory authorities in other countries, so that, because we know that drugs knows no boundaries, issues of importations and distributions and all whatnot. Nigeria is not able to make all the medicines that they require for use in countries. So a lot of them are quite imported. So pharmacovigilance knows no boundaries. And for us to ensure patient safety, we need to continuously monitor the use of these medicines, collaborate with other regulators, put in place measures to minimize risks reaching to the patients, and provide appropriate and timely information to relevant stakeholders to ensure safe and rational use of medicines in the healthcare system in Nigeria. So to implement pharmacovigilance, there is need to understand the legal and regulatory framework for the drug safety monitoring in country. So the goal for pharmacovigilance, we know, is helps us to detect early, increase in frequency of previously unknown adverse reactions and interactions, and other noxious drug-induced problems. In this manner, it helps us to identify signals, new signals that have not been known, even increases in frequencies of known adverse reactions because of the way medicines behave. A lot of interactions can happen, thereby increasing the frequency of even the already known adverse events. It also helps us to identify predisposing risk factors and possible mechanisms underlying adverse drug reactions. When we understand the predisposing risk factors, it helps us to curtail the occurrence of it within our patients. It also helps us to promote rational and safe use of medicines, educate and inform the patients. Remember, the patients are very central to everything we do in pharmacovigilance. Every one of us can be a patient at one point in time. So pharmacovigilance is a collective effort by all, because at one point we may be at the side of the healthcare provider. On one certain point, we may be even the patient. So pharmacovigilance helps us to assess and communicate risks and benefits of medicines on the market and support the dissemination of information needed to improve drug prescribing, use, and regulation. Remember, what is not documented is not done. For any drug treatment process to be beneficial, the benefits must outweigh the risk. And that is what pharmacovigilance ensures in Nigeria. How can we continuously improve the benefits of medicines used in Nigeria and reduce the level of risk that gets to the patients? So the structure of pharmacovigilance in Nigeria is such that the National Pharmacovigilance Center is central and has interactions with different stakeholder groups. We have the Director General who reports to the Honorable Minister of Health. But from the other link, we have our 6 zonal pharmacovigilance centers. We have NAFDAC offices in all the states of this federation. And we have even PV focal persons at the states, because we are now decentralizing pharmacovigilance in such a way that we will get closer to the patients, closer to where it matters, rather than situating it at the central. We at the central in NAFDAC are only a coordinating organization, but the actual pharmacovigilance functions are placed out in the hospitals, in our homes, in the society. So for us to be able to get improved pharmacovigilance, NAFDAC has decentralized pharmacovigilance implementation. And that's why we have the national at the center, and we have the 6 zonal pharmacovigilance centers in 6 tertiary hospitals in 6 geopolitical zones. Then we also have interactions with public health programs that we have in Nigeria, the HIV, the malaria, the vaccine, just name them, we interact with them. Then marketing authorization holders are a key component of our interactions because they are the manufacturers and the distributors of this medicine. So pharmacovigilance is mandatory for them to put systems in place to be able to monitor the safe use of these medicines. And then Pharmacovigilance Center also interacts with different healthcare providers, stakeholders, just like the doctors, pharmacists, medical labs, and all those. And we are also working towards institutionalizing PV units in healthcare facilities. Currently, the tertiary, secondary, and primary health facilities. Nigeria, we are currently conducting pharmacovigilance assessments across health facilities in the country, and just to institutionalize and ensure that they form pharmacovigilance committees that will continue to be the gatekeepers for patient safety in these different health facilities. So the zonal pharmacovigilance centers we have in the different zones is in this situated in these hospitals. In the Northwest, we have the Ahmadu Bello University Teaching Hospital, ABU Zaria. North Central, we have it in the Lorry Teaching Hospital. In the Northeast, we have it in the Maiduguri Teaching Hospital. Southeast, in the Federal University Teaching Hospital, Owerri. South-South, University of Benin. And in the Southwest, Lagos University Teaching Hospital, Luth. So they interact with us, we work with them, and they are to continuously carry out pharmacovigilance functions within the zone so that it will be a coordinated mechanism in terms of patient safety in Nigeria. So what is the scope of PV in Nigeria? We're looking at issues of not only drugs now. Medical devices are coming to the fore because we are seeing in our health facilities that a lot of medical devices that are used in the hospital, patients react to them. So pharmacovigilance is expanding its scopes to the medical devices, vaccines. We all know adverse events following immunization, cosmetics, when people use cosmetics and they react, issues of chemicals, and more importantly, herbals, because we know that in our system today, apart from taking orthodox medicines, people also combine orthodox with herbal medications. So as the doctor is treating in the hospital, somebody is by the side telling them, oh, this herbal medication cures all diseases. So we begin to see patients taking both orthodox and herbal medications. And all these concussions are predisposing risk factors for the occurrence of adverse drug reactions in patients. So in monitoring patients, when they develop adverse drug reactions, we must do well as healthcare professionals to probe whether they are also on other concomitant herbal preparations and a lot of cocktails of other medications, so that we get to the root of the causality for the event. Then the legal framework in Nigeria, just like I have said, NAFDAC is mandated by the Act Cap N1 laws of the Federal Republic of Nigeria. And this mandates NAFDAC to control and regulate the manufacture, importation, exportation, the distribution and advertisement and sale of food, drugs, cosmetics, detergents, medical devices, and all drinks, including packaged water. What are we ensuring? Safety. In addition to quality and efficacy, safety is a critical component of medicines and other things that we use. Because when we treat patients and they are reacting instead of getting better, it discourages them to even continue their medications. So pharmacovigilance is a critical thing that everybody must pay attention and due diligence, because if we have patient safety at the center of our hearts, it makes it possible for us to follow through with our patients. So we have a national policy on pharmacovigilance, and the policy provides a strategic framework for the entrenchment of pharmacovigilance in the health systems in Nigeria to ensure the overall safety in the use of medicines. In addition to the policy, we also have regulations, because you know that policies are there, but PV regulations are enforceable. So it was gazetted and published in Nigeria in 2021. We now have a regulation on pharmacovigilance. Then we also have the good pharmacovigilance practice guidelines for the marketing authorization holders and the public health programs in Nigeria. This guideline helps everybody to understand their roles and responsibilities in terms of pharmacovigilance. All these documents are on our website, www.nafdac.gov.ng. So once you go there and click on regulations and guidelines, you will see plenty of different guidelines and regulations related to the NAFDAC functions in Nigeria. So you can click and download the pharmacovigilance policy, the regulations, and also the guidelines there for better understanding of roles and responsibilities in country. Then in terms of methods of reporting, methods in Nigeria, we say, okay, for the healthcare providers, it is our professional and ethical obligations to our patients. We know that we are not the manufacturers of these medicines, but because of our ethical responsibilities to our patients, we must pay due diligence to what happens to them during every treatment process. So we use the reports made by healthcare providers to checkmate what we are receiving from the manufacturers and the distributors of these medicines who use them for business purposes. So healthcare providers are required to continuously monitor their patients. Patient counseling and education during the use of medicines is very, very critical. We as health providers and health professionals must ensure that we continuously integrate that in our day-to-day running of our professional responsibilities to the patients. Then to the manufacturers, we say it is very, very critical that they continuously put a system in place for the for pharmacovigilance. They should put a system in place for pharmacovigilance. By giving us their structure and system for manufacturing, and that they also have a qualified person responsible for pharmacovigilance in country. So methods of reporting, we say passive pharmacovigilance, which is the spontaneous reporting, whereby healthcare providers see what whatever they see during the course of their practice, they will report. So when we talk about passive pharmacovigilance, we say there is no active measure to look out for adverse events. So it is what we have seen in practice that we will report. And this passive pharmacovigilance covers all the medicines. There is no specific medicines that is limited in passive surveillance, passive pharmacovigilance. Whatever medicine a patient is taking at any point in time for any disease condition, if there is a reported adverse event, it is critical that it is reported. So spontaneous reporting helps to detect signals of previously unknown problems. And also healthcare providers should see it as their duty to report any suspicions of adverse events in patients under their care. Then we have the second method, which is the active pharmacovigilance or the hot pursuits. This is when we have new medicines, new vaccines that we're looking at a particular group of patients or for a particular disease condition. We want to actually do an in-depth monitoring to see what is actually the patterns of adverse drug reactions or events associated with that use of medicine within a particular population or disease condition. So we use the active measure, and the active measures taken to detect and report adverse events. It involves active follow-up of patients and recording all medical events. And follow-up is either done prospectively or retrospectively. For example, is when during COVID, because COVID-19 vaccine was a novel vaccine, and a lot of the clinical trials were not done within our own population. Being that the world was in a pandemic mode, we needed to bring in those vaccines and also vaccinate our people with them. And as a result of that, for us to characterize the safety profile of that vaccine, of those vaccines within our own population, we had to do active monitoring of those vaccines within our own population to generate homegrown data on what is the safety profile within our own population. We're doing that. And we also ask healthcare providers for new medications used in the different patient groups that their true safety profiles are not known. You can institutionalize that in your health facility. That's a kind of partly a research mode. So you follow up, and anything you identify, you are able to report it. Then the individual case safety reports, we all know, is just the format and the content for reporting one or several suspected adverse drug reactions to a medical medicine that occur in a single patient at a specific time. So when a patient takes a drug and is reacting, for example, one drug that could cause like 2 or 3 adverse drug reactions, we use the individual case safety report form, the yellow form. I'm sure a lot of us already have seen that in the past. Now it is no longer the yellow form, it's now the current white form. But in order to improve reporting, we have tried, after doing a gap analysis to see how we can improve our practice in country in terms of reporting, we now have translated those paper forms into an electronic format. So we know about the MedSafety app. I'm sure a lot of us have heard about it. Prof mentioned it. The study that we did pre and post introduction of the MedSafety app to see the impact in terms of reportage. And that has actually improved our reporting. We introduced it during the COVID-19 vaccine introduction. And that was really a game changer for us in Nigeria to be able to contribute data to the global database. So the minimum criteria for a valid ICSR is that there must be an identifiable patient, an identifiable reporter, the suspect drug that we are reporting on, and what is the event or outcome of that event. So once you're able to provide these 4 key components in your reporting form or through the MedSafety app, that means that whatever report you have sent to us is something we can actually analyze, do causality assessment on, and be able to improve reporting. Who should report? Everybody. Who should report? Everybody should report, whether you are a doctor, a pharmacist, a nurse, community health workers, traditional medicines practitioners, because of issues of herbal medications, the community, the medical lab scientists, all of us, even the public, the patients can report, because the Med Safety app, we have made it in such a way that the patient can actually react, and if he knows how to use, I'm sure a lot of us have Androids and iPhones and are really very tech savvy. So if you don't want to go to the clinic and you are able to download the app from the Play Store, and you're able to give these 4 components: who is the patient, who is making the report, what is the product you're reporting on, and the adverse event on that form, and you submit it. We do causality assessment, and we're able to get back feedback appropriately on what medicines are causing within our own population. And what is to be reported: all responses to medicines used in humans which are noxious and unintended. And we're also looking at issues of lack of efficacy, being that a lot of counterfeit medicines are already circulating within our uh, communities. So lack of efficacy, you're taking a particular drug and you're not seeing results. It's a reportable event that will help NAFDAC to track those samples, because when we get like 3 or 4 people reporting, oh, we took this particular drug and they are not seeing any effect, it enables NAFDAC to go into the market and take samples for laboratory analysis. And this is one of the ways we track substandard and falsified medicines. Issues of overdose, misuse or abuse of medicines, medication errors, and counterfeit medicines are all reportable events in the pharmacovigilance balance. So when should we report? We said it is a suspicion. Once you suspect that an ADR has occurred, please report. Whether is it serious or not? If it is serious, please report. Is it a new drug? Yes, report. Even when you're not sure that it's an adverse drug reaction, but it has happened after taking a medication, please do report, because we can only ascertain this the drug event interaction after causality to say, oh, it is this drug that caused it. Oh no, it is not this drug. It could be another thing. So if we don't report, we cannot make sense of what medicines are causing within our own population. So it is the responsibility of every one of us to pay attention to what happens to our patient, grant patient education, because without awareness, what you don't know, you cannot give. So increasing the awareness of pharmacovigilance is a critical component of our day-to-day lives as healthcare providers. We must pay due diligence to this, because without the awareness, people will not know what is happening. And we have different reporting tools already available: the paper form, the Med Safety app, and the e-reporting. All these are linked. All the information generated from this data, different reporting tools, enter into the national database, which is the VigiFlow. So whether you're using the e-reporting platform, or you're using the Med Safety app, or you're using the paper form, at the end of the day, all the information gets into our database, which is the VigiFlow. The Med Safety app can be downloaded from the Android Play Store or the iOS for iPhones. So we just search and we download it. And once we download it and tap open and register it under Nigeria, because other countries are using it, because it has become an effective and efficient tool for reporting. Once you register and put in your emails and create a password for it, you are already home with it. It goes with you. The form goes with you anywhere you go, such that when there's an adverse drug reaction, whether to the person or to any member of their family, or from a healthcare provider to a patient, they are easily able to report this. So it removes the gap in trying to say, oh, we fill the hard copy form. Where are we going to take it to? How do we get to NAFDAC, so that at least whatever we have reported will get to the regulator? So by using the Med Safety app, it bycuts all those gaps and challenges, that immediately you fill out that form and you click on submit at the end of it, the form immediately goes into the database. And we have healthcare providers who are looking at the database, reviewing the reports that we have gotten, and we're able to provide adequate feedback to the community. So what can be reported? What can we do with the Med Safety app? We can report both ADRs, AFIs, side effects, track drug-related safety information. We can also build a watch list of medications to see what is happening in the global arena. with that particular medicine, and we can view the number of reports received in the WHO database of the suspected ADRs for particular medicines. We also have the newsfeed where NAFDAC also provides information on alerts on medicines that we have generated in country. So the Med Safety app is a very wonderful tool. It provides information. It also enables you to report conveniently from the comfort of your home once an adverse drug reaction happens, because by downloading it in your phone and you're carrying your phone, obviously we carry our phones everywhere. It means that we go along everywhere we go with the ADR report form in our pockets, so that once we see it, we report it immediately. So what will happen to my reports once comes into the database? We'll review it, do causality assessment. If it is a critical one that requires feedbacks and patient education, we kind of develop information on that through our newsletters, which we circulate. And we also send the reports to the global WHO global database. What are the benefits of my ADR reporting and monitoring? It reduces drug-related problems, leading to better treatment outcomes. It will also contribute to global knowledge on drug safety issues, provide access to feedback information on drug-related problems reported within the country and internationally. Most importantly, it guarantees patient safety, which is the bedrock of pharmacovigilance. It also provides satisfaction for the fulfillment of a moral and professional obligation, and enhances patients' confidence in practitioners, improving the quality of care that we offer to our patients. Remember, patient safety is central to all we do in our clinical practice, so we must always uphold their safety in whatever we do. So what are the challenges in pharmacovigilance that we have experienced? We know funding can never be enough because a lot of people need to know about pharmacovigilance. Underreporting of ADRs and AEFIs is very high. Yes, we know that we see all these ADRs, but people to make out their time to actually report them is quite challenging. But we'll keep working and working and working until we get to our final destination. And our final destination, as we all know, is ensuring that patient safety is at the center of every healthcare professional practice. Lack of awareness and training, we are conducting trainings and building awarenesses, providing jingles for pharmacovigilance, posters, and in any format. Our NAFDAC and Your Health also provides opportunity on pharmacovigilance education through medias and others. Then another key thing is multiple reporting channels. Different stakeholder groups having different reporting channels on pharmacovigilance is one thing that is causing a lot of problems. So we're looking at ways we will continuously integrate with them to harmonize reporting tools, because any report on ADR or AEFI that does not get into the national database obviously will not contribute to informed regulatory decisions made on drugs that we allow to be used in our markets. Issues of poor communications among stakeholders, including patients and healthcare professionals, hinders reporting and monitoring of adverse drug reactions.
From Elemo, sorry, I just want to inform you that you have 5 minutes to summarize because of our time. Thank you
I'm
so
even
much.
finishing before 5 minutes. Thank you.
All right,
So
thank you.
issues of limited resources and infrastructures for reporting and difficulty in obtaining timely and accurate information is a huge challenge in our country. So we have to continuously work together as healthcare professionals to improve pharmacovigilance in Nigeria. What are our achievements? We have achieved the maturity level 3 based on the WHO Global Benchmarking Tool, which is a tool used to benchmark countries. Nigeria currently is on maturity level 3, even our pharmacovigilance. We're working towards getting the maturity level 4. Then there is continuous training of healthcare workers and other relevant stakeholder groups to improve their awareness and knowledge on pharmacovigilance. We have also started the PV inspection of marketing authorization holders so that we are sure that they are having systems and structures in place to monitor the medicines that they put in the market for use. Currently, in the healthcare facilities, we are conducting health facility assessment across the country, all targeted towards institutionalizing pharmacovigilance in their different healthcare settings, so that the pharmacovigilance committees can become functional and be able to create awareness within those hospitals. Increased public awareness on PV is currently ongoing through different stakeholders' engagement in PV. So a lot is happening in the PV space. And I'm also happy that we're also working together with our group, this group that has put up this wonderful webinar to improve pharmacovigilance awareness within the country. In conclusion, pharmacovigilance, we know, is our collective mandate. Patient safety is central to all health professionals. We therefore call on institutions and professionals to continuously strengthen pharmacovigilance and participate in everything and activities that involve pharmacovigilance. We know that by working together, we will make Nigeria great and make patient safety a critical component of our daily practice. Thank you so much for giving us the opportunity to present during this webinar. I will continuously work with this group in furthering pharmacovigilance activities in Nigeria. Thank you.
Oh, wonderful. Thank you, Dr. Uche. We can see that she just does not work with NAFDAC. She's passionate about what she does. And I want to thank you very much for that very detailed and passionate presentation. And so we'll take some questions at the end generally. So I would just want to call Dr. Onyinye Akune. I think she has something to tell us just for some few minutes about, again, continuing the discussion about pharmacovigilance and about the results of one of the study that was conducted, the paper recently published, so that we get this discussion enriched further. Thank you. Dr. Akune, you have the floor.
Thank you very much, Prof. Fadari, and good evening to everybody. I'm delighted to share with you insights from our recent study that we conducted. Now, the findings from this study was generated from the stakeholders engagement that we had last year in March. The stakeholder engagement was there to strengthen pharmacovigilance in Nigeria. And just like we've heard Prof. Oriagba say at the beginning of this webinar, it's very important for stakeholders to work together if we hope to achieve a society where medicines use is safe. Then everybody has to have their hand on deck so that we ensure that safety of our medicines is paramount. Now, as we've heard from Dr. Uche Elemuwa, Nigeria's pharmacovigilance system has evolved over time. So since the institution of the National Pharmacovigilance Center in 2004 till today, there has been a lot of changes and evolution. But we all have to admit that there are certain gaps that still exist. And it is important that we look at these gaps as a group so that we can see ways we can strengthen the system and ensure safe use in our society. The objective of this paper, as it were, is to present what we discussed at that meeting. So at the meeting, we assessed the current pharmacovigilance landscape in Nigeria. We tried to identify some barriers and some enablers that would encourage good adverse drug reaction reporting and improve general use of medicines in the society. We also hoped to develop insights into policy, institutional, and practice reform. So it's not just all about sitting and talking about the problem, but how can we go from problem to solution? how can we offer insights that would strengthen the system? Now, like I said, it was a stakeholder engagement that went on for about 3 days. And we used a qualitative participatory engagement approach where everyone was allowed to share their practical experiences and also share what happens in their institutions. We generated the data from the stakeholders' perspectives. Some of the key findings from our meeting was that we have structures already in place rather, that enables good pharmacovigilance reporting and the system in general. So one of it is the decentralized structure, and Dr. Enemuwa has spoken and has explained that to us at length. So NAFDAC actually has the decentralized structure, making the PV centers closer to the grassroots. So it's not just the national centralized system. We also have the mobile reporting tools, just as it has been mentioned. It's able to, we are able to use our mobile phones to send adverse drug reaction reports to the National Pharmacovigilance Center. We noticed that, or we deliberated bringing forth some of the multi-system barriers that hinders the coordination and clarity of roles in the system. So multi-level, because we looked at the national at the national end, and then institutional, the hospitals and all that, and also the patients. One of the findings that was highlighted is that we have training gaps, right? So where there's limited resources in terms of manpower, in terms of fund and other resources, we also have training gaps that persist at all levels. An issue that came up also was the low awareness of adverse drug reaction reporting among healthcare workers. And not just about, when we talk about the awareness, not just about them knowing that there's something like adverse drug reaction reporting, but also knowing the importance, right? So with the awareness also comes the importance. There was a low awareness about the importance of adverse drug reaction reporting among healthcare workers, and also the public. Patients themselves do not actually know the importance of adverse drug reaction reporting. We also, another issue that came up was weak institutional communication. So where the feedback system from the institution to NAFDAC, and NAFDAC giving them a feedback to whatever reports they have generated, there was that weak link or weak communication and data sharing across systems. It was also highlighted that there's an absence of performance monitoring that limits improvement efforts. So we know with everything we do, if we keep on sending out reports, there must be sort of a performance monitoring system in place so that we get feedback and we are assured that whatever reports we are sending across is actually doing something good. So we saw that the approach we have to take, so there are a lot of gaps, there are a lot of problems in the system, but we shouldn't take like a one approach to solve the problem. We have to look at all the problems and then see how we can generate interconnected strategies to improve the system. So a lot of the areas we can strengthen is given out in this lovely figure, the lovely diagram here. But we shouldn't look at the problem solving from one end. We should look at how we can solve it as an interconnected, in an interconnected way. So what is the implication of all this? What's the implication of our findings? I'm just going to zoom in on two of the implications. The first one is the implications for training and capacity building. So there is actually a need for practical competency-based training for our healthcare workers. So healthcare workers need to know the importance of adverse drug reaction reporting. We also have to integrate PV, pharmacovigilance, into our pre-service education. So undergrad pharmacy, nursing, and medicine schools have to have PV integrated in their curriculum. We should also expand on in-service training and mentorship, and also promote multi-sectoral collaboration between the regulators, academic, and the public health, so the population. The second implication I'll talk about is the institutional and policy implication. So, like it has been highlighted over the course of our discussion, we need data, we need research to actually inform our next move. When it comes to pharmacovigilance and the safety of the medicine in the population, research is vital. On that note, we need to strengthen the coordination between NAFDAC, the NREC, and the Ministry of Health, even with the academia, so that we would generate research and findings that can improve medicines use in our in our population. We also need to formalize data sharing protocols between institutions. So data was something that came out as quite a challenge, where we don't have a similar or shared structure of collecting this data. So there has to be a formalized data sharing protocol between institutions. We also need to embed PV in our national strategic plans and budget. There has to be clear budget lines for these activities. We also need to encourage the use of PV data for programmatic decisions and for regulatory action. Now, I took out a quote from the article, and that quote says, "Success depends on sustained commitment, adequate resources, and effective stakeholder coordination." So for us to be successful in our PV efforts, we need to have dedicated resources for that. We need to have people that are passionate about pharmacovigilance, and also have a good coordination strategy, so that everybody works together for the greater good of the public. So on that note, I'm going to hand over to Mr. Shadrach Eze to talk about the training that we'll be having in September.
Thank you so much, Dr. Inye. I'm sorry, Inye, I'll share my screen because
Okay, no, that's fine. You can go ahead.
Okay. Yeah. Okay, so we have thanks to all the speakers before me, we've talked about a real important gap, which is capacity building. And in line with this, Kwapila Health Research Foundation is committed to bridging this gap between what is available in terms of capacity. When we talk about capacity, we are talking about like how much people know about pharmacovigilance and then rational medicine use, and then how much do we implement it? Do we have the right tools? Do we have the right knowledge? And then, as you saw from our boss in NAFDAC, they have set everything in place, but sometimes we don't even know how to use this. We don't know that they're available. So in line with this, Kwapila Health Research Foundation is organizing a capacity building training later this year in September. So it's a training that will hold in Lagos. And then so I'm here to update us about the training, who can attend, what do you stand to gain, what are the processes to register, and then all other things. So now let me start by who should attend this training. if you're a student interested in health research, you might not be in the sciences, can be anywhere, but most likely you're a health professional, or maybe you're already practicing as a health professional, you're a pharmacist, you're a doctor, whatever, you are invited to be here. If you're interested in data along the path of healthcare, even if you're not a healthcare professional, you are invited, because when we talk about pharmacovigilance, we talk about evidence-based research, we are talking about data. So you are invited to be here. And then every other person, every stakeholder. If you're a patient and you want to understand how do we as patients do our work, because we just said that the patients too are very, very important in reporting and then many activities in pharmacovigilance. You are invited to attend. Now, why should you attend? Okay, so you're attending because we'll lay to basic things about evidence-based research. How does it apply to the different stakeholders? How does it apply to you as a healthcare professional? How does it apply to you as a data analyst? How does it apply to you as a patient? If you're a policymaker, how do you integrate this into your work so that your policies do not actually obstruct the functioning of the system, and then how it should work to help us make the process very, very easy to work with. All right, so now I'm going to show us the very easy process on how to register for this program. Also here we have support and then over that. So maybe if you need work leave to attend the program, or maybe you're coming from outside Nigeria and you need a letter to help your visa and whatever, we will also provide this support and opportunities for you. Okay, so this is just a very simple banner for the program. It's going to take place in Godfield Hotel, Ikeja, Lagos, from 9 to 11 September. It's a 2 days full program, although we start from on the 9th, and then maybe the 10th and 11th. So as I've already mentioned, the things to learn involves pharmacovigilance, research design, ADR reporting, and then most importantly, data. How do we organize data to solve some of these issues? I've attached here the link on the link where you can register. So I'll just give us a peek. So if you click the link and then you come here, it will bring you to the main page of Kwapila Head Start Foundation. And as you can see, everything is set. You can access the home, the register button, travels. Maybe you're coming from outside Nigeria or from anywhere within Nigeria. How do you access the place, the program of events, and then obviously the speakers. Now for registration details, as is shown here, if you're a student, you will pay 40,000 naira to participate in this 3-day program. If you are a healthcare professional already practicing out there, you're a consultant or a stakeholder, you will pay 70,000 for this program. All right. So and then I think that's all. If you have any other question, you should let us know. I'll paste this link on the group chat, so on the meeting chat, so that you can access it. All right. Thank you so much, Dr. Ine.
All right, thank you for that, Shadrach.
Okay, thank you very much.
So no, yeah, so
okay, you still have
Shadrach
some
actually
additional
presented.
things. Okay.
Yeah, he actually presented in between my presentation as planned. Okay, so I just want to say some things in addition to that this training in September aligns directly with what we've been talking about, right, previously, the need for locally generated evidence. So this training helps in our evidence-based generation locally. It also helps to develop a network of trained professional across all sectors, just like Shadrach said. If you're a healthcare professional, if you're a regulator, you're the public, the patient, and you want to know more, then you should attend. It also equips you with tools that you need to drive institutional reform. And I just want to say that we are hosting this training in collaboration with the University of Lagos. So if you attend this program, you would also be given CPD points for attending. Thank you very much. I have my contact here in case you want to reach out to me in future to ask any questions or to get further information. Thank you very much.
So thank you. Yeah, Dr. Iye. So thank you for telling us about the training and how to register and all that. So I think we spend a lot of time. So I posted something in the chat area. If there are questions, kindly write your questions or comment down, but I can see some hands up. I'm sorry, I don't know the full name, but I can see Bilikisu and I see Ibrahim Mamidu. So I will take Bilikisu first. Please make it brief.
Okay, good evening, everyone, and thanks to all the presenters. So mine is not just a question, but a comment, and at the same time, I would like to hear what can be done. My name is Bilikisu Amdaoladeji, and I work at the Lagos University Teaching Hospital, Children Emergency. So what we normally see is not, it's all about underreporting. And one thing I found out that causes it is there is no enough public awareness. Most of the caregivers, when they come and there is adverse drug reaction, if you ask them, they will tell you, this is what I give. The baby had a high-grade fever, and I went to a patent medicine or a chemist. I was given anti-malaria. When the temperature didn't go down, my neighbor gave me palm wine, and I gave 7 keys. You'll just be hearing sort of, but when you now ask them, please, where is the pack of the drug? Where is this? Where is that? So that we can make adequate report. They will tell you they don't have it. Okay, can you send someone from home? Someone will tell you, I live in Ikorodu, I live in Aja, but I don't have all this information. Okay, tell someone to send it, maybe snap it. At the end of the day, you will not get anything. And this is one of the reasons why we still have under-reporting. So I believe there is need for public enlightenment. If there is any adverse reaction, the caregiver should always come with the pack of the medications or even concussion, anything, so that we can have evidence and we can have an appropriate document. And the med safety is also very, very okay. I've used it, and immediately I used it. There was a response that okay, my all the informations, they already got it. At the end of the day, we won't be able to use med safety, because if the information required to be fed on this med safety is not given by the caregiver, there is no how you can move to the next. So the med safety is like, if the information is not there, we won't still be able to use it. So there is need to hamper more on public enlightenment to what to do if so thing happen. And if you are taking your baby to the hospital, this is what or a relative or someone should take along, so that we can have an appropriate documentation. Thank you very much.
Thank you very much, Ma, for bringing that up. That will be is noted. As Ibrahim Amidu.
Yeah, thank you so much, Prof. I don't know if I'm audible, sir.
Yeah, we can hear you.
Thank you very much again, Prof, and good evening all. First, I want to appreciate all the speakers for the very insightful and stimulating presentation. And then secondly, I want to also quickly appreciate Professor Ibrahim Oriagba and Dr. Uchenna Elemua. These two are actually very instrumental in my journey pharmacovigilance. Through their help, today I'm a consultant in pharmacovigilance. Thank you very much. Then my own question, comment, or contribution, as it may seem, is actually from experience. Recently, I had engagement with healthcare professionals, and after I have run through pharmacovigilance with them, the question they ask me, I will just ask them directly also here. And why I want to do this is because I know that we have a dynamic mix of professionals here. And I'm sure that their insight will be helpful in also advising with regards to this. So number one is, the question they asked was, they asked me, they say, pharmacist, that your presentation is actually very, very important, and they have seen the indispensable need of pharmacovigilance. But why is it voluntary for healthcare professionals? That because we are Blacks and we have attitudinal problems, whatever is voluntary, even if it's important, there is the likelihood that it will not be reported. So why are we still saying that it should be voluntary for healthcare professionals, seeing the very dear importance of this pharmacovigilance? And because even the pharma companies rely on reports coming from the healthcare professionals, so why is it voluntary for us? So I think it's something we should start reflecting on. And then the other issue was the issue of litigation. Even I try to defend that no, litigation doesn't really apply, but they still have that concern. I could see that they still have concern about litigation, that most people will not want to report because they don't want to point fingers at them, or because they don't want to appear in court to start defending something. So I think it's another concern that is actually that arose from that meeting. Then finally is also to complement the earlier speaker that made a comment on regards to Med Safety app. So now we have the Med Safety app. We also have the NAFDAC ADR e-reporting, which is also now in form of an app now. So they are asking, okay, which one? Like, let me tell them which one should they use. I say, okay, no, you can use either the Med Safety app or the NAFDAC ADR reporting, but I say that no, which one should they actually work with? So these are my few comments, and thank you very much for the opportunity to make these comments. Thank you so much.
Thank you, sir. And Omolola, your hands up. You have the floor. So Omolola, yeah.
Yeah, good evening, everyone. Are you hearing me now?
Yes, we can hear you, ma'am.
All right. Thank you so much for this presentation. I know that our time is fast spent. Let me just go straight to my question or my observation. I was just asking myself, I actually looked forward to this particular training because I know that it's very relevant to us as healthcare workers. And the question that was rolling through my mind as this training was going on is, now we have attended the training, what are the action plans for us? What are we rising up from here to go and do? I know that sensitization among healthcare workers is also very key. Our attitude as healthcare workers in detecting, in assessing, and in reporting. And possibly, just like one of us has said, a lot of bottlenecks, bureaucracy that are very hard to crack in reporting some of these cases. You see a lot of our colleagues are not willing to go far in detecting and in reporting. Because when you're asking a patient for a pack and she cannot actually present it, and you have to document all of this in the ADR reporting booklet, it can be so very frustrating. I work with HIV patients, and I've also found myself in that situation too. So in order for us to create more awareness among our professional colleagues and for them to be motivated attitudinally, so that we can be very sensitive to detect adverse drug reaction. I don't know, I was asking myself, what are we rising up from this training to go and do? I think we need an action plan. About 72 of us or 70 of us have participated in this training. What can we do together? What can we achieve together so that we can also be able to sensitize our colleagues on the need for pharmacovigilance? That is the first thing I want to say. And secondly, in detecting whether a particular symptom is based on adverse drug reaction or caused by an underlying disease condition, that thing has been very, very challenging for me. But I've learned here today that whether you are suspecting that it is caused by the drug or something else, just report it. So for me, it's something I'm going on with. But I think we need an action plan from this platform. 70 of us attending this training. What is our action plan? Thank you very much.
Thank you, Ma, for your comments and the queries, especially regarding the action plan. Dr. Oluchi, yeah, maybe you can just tell us a few more things, just a few minutes.
Thank you, Prof. Fadare, and thank you to everyone for the wonderful presentations. Apologies again for my connection, please. I just thought of something as Dr. Bilikisu was speaking, and I think it also ties into what the last speaker said about raising awareness amongst not only our patients and the public, but also among healthcare professionals. If we know that all of us have the responsibility to report PV data, then we will take that also more serious. But what I've also seen in some cases is that when patients want to report as well, they do not feel empowered or they do not feel the resources to do that. So in my work as a pharmacist, on many occasions, I come across patients who want advice on the medicines they are taking. And
Oh, network has come in again. So I'll just read one thing from the chat while she's reconnecting. We have two comments or two questions there. There is somebody, I think, let me see again. Henry Chukuma. He was asking a question about the role of fake and substandard medicines, including cosmetics, and what NAFDAC is their role in causing adverse drug reaction, and what NAFDAC is doing in this regard. I think Dr. Uchenna, if she's still on, she can help us to say something regarding this. That's the role of NAFDAC regarding fake and substandard products and adverse drug reaction.
Okay, thank you so much for the question. I think my presentation actually enumerated our roles and responsibilities. So a lot is also being done with respect to fake and counterfeit medicines. We have our post-marketing surveillance directorate, just like the PV, before they were together. But because of the enormous work that needs to be done in terms of ensuring that product quality, we have the PMS. They do good distribution practice monitoring and surveillance. We also have the substandard and fake substandard and fake falsified medicines guidelines and actions that were put in place in terms of reportage of suspected counterfeits. We are aware that currently, about last 2 months, NAFDAC underwent a cleaning up of markets where medicines are being sold. Lonita Head Bridge, Lagos, Kanu, everything. And a lot of fake and counterfeit medicines were identified and destroyed. Some people were brought to justice, sued, and things like that. We know that in country, there is need for political will to actually put in stringent laws that will deter fake and substandard counterfeiters, because they're actually even overwhelming the people producing genuine products. You can imagine somebody who is spending money and putting the right things in place, then somebody comes and clones your medicine and is selling it at a very cheaper price in the same markets. And this same attitudinal problem is something that has to be addressed both for safety and quality, because looking at the realities of the economy, people will say, oh, it's medicine, it's generic. Oh, if it's a cheaper one, let's buy the cheaper one because of the economic crunch in the country. But the fight for fake and substandard medicines is not only in the hands of NAFDAC, it is also being put back in the hands of the general public. We have the Green Book, where we publicize original brands of medicines.
And we also have different tools to report that. So it's a call to action for everybody. As much as the regulator is working towards curtailing their unscrupulous activities, the public also needs to be hands-on on it, because we can only keep this country clean up this country if we all join hands. When healthcare providers say they will not buy fake, but one question you ask me is, how will they know fake? A lot of fake products, when you even see their packaging, you will know that, oh, this one has an issue. But a lot is being done. There are lots of guidelines, regulations to control that. WHO is working with countries in concerted efforts to fight counterfeiting and substandard medicines. But that's where we are in country. They are still there in the market. NAFDAC is working towards cleaning them when they are identified. Through the pharmacovigilance reporting, when we identify them, we also track them. And those unscrupulous businessmen, we are also fighting them to a halt. So it's all working together to sanitize our country. Thank you.
Thank you, Ma. Thank you for that. There is another comment somewhere in the chat by Jay's iPhone. I'm sorry, I don't know the full name, but what the person said is the person recommends that health educators in the hospitals should take the initiative to talk to patients during their visits about the tools and channels for reporting adverse drug reactions. And I think that is a very good suggestion, and that all of us is part of the things we can take away from here, talk to our networks within our healthcare facilities, and also to make sure that we put these, especially the public health units, so that people can, as they talk about non-communicable diseases and other things, they should also tell them how to report adverse drug use. So using these apps and this online this thing. And I think Dr. Oluchi, yes, she's talking about getting healthcare workers on board, and so that we can sensitize patients, engage patients and sensitize them regarding adverse drug reporting. Okay, Zainab Bagbaje, thank you very much. And so I think what we need to take away from here is, the action plan. Again, we are from diverse backgrounds attending this workshop. And I think the mere fact that we spent 2.5 hours listening to all these things means that we are really committed, that we are passionate about pharmacovigilance. And so their action plans can be formal and informal. So I would just say that the informal one, it's a commitment from each and every one of us to do what we can at our own separate units to promote pharmacovigilance, either through stepping down, discussing with our colleagues, discussing with our patients when we see them, or trying to get our the management of our various units, healthcare facilities, to think about pharmacovigilance and this new approach all over again. And the former one, yes, if there's anybody in position of authority in any of these healthcare institutions, I think it's an opportunity for us to sell the idea of pharmacovigilance or revive it in our healthcare facilities if it's been dormant. And I think the training coming up in September also gives us another avenue to actually come out with a position paper, because we are going to have people from academia, people from industry, people from practice areas, community pharmacists, hospital pharmacists, and everybody will be there. And then, and we are already engaging with the Federal Ministry of Health and some other government parastatals. So I think it's an opportunity to break into that cycle and to be able to, how do I put it, contribute to policy and to practice. Because if we have a policy and it's not practiced, then really we are not getting anything done. So I think that is, from my own point of view and from the summary I've heard from what other people are saying, that is the the action plan for now. Sensitization of patients is very important regarding adverse drug reporting. Yeah, so we need to sensitize our patients to know that they can report also themselves. And we need to educate. We need to talk to our patients more. That is very important. I don't think we talk to our patients enough. Maybe because we have many patients, we have few healthcare personnel, but I think it's still an obligation. It's something that we must do to talk to our patients and educate them, and so that they know the importance of this. Thank you very much. Dr. Onyinye, do you have
Yeah,
some final words?
yes. So, yes, I do. I just want to add to what you have said about the action plan and going on from here, because that is always important. When we sit at meetings like this, you want to ask yourself that, okay, what is all this leaning to, or what can we do from here? We don't just sit with our problems, but we look for how to make things better. So I also think that a good action plan is to continue to collaboratively work together, because we need everybody on board. We need all hands on board to make things better. And it's also going to be a continuous process, because here we are looking at how to change behavior. So it's a behavioral thing and it takes time, like over time. So we just have to keep looking at what works, what doesn't work, and keep on from there until we get to a good or a better place. Yes. Um, and on that note, I just want to thank all of us for our time. Thank you for participating. Thank you for being here. We appreciate your time and we hope you've learned one or two things. And we really look forward to seeing you in September and, continuing the dialogue. Thank you very much.
So thank
Prof.
you.
Fadari,
Good night, everybody. Thank
Thank
you
you
for
so much.
participating,
Thank
and
you,
thank you for
everyone.
spending time.
Good night.
And we hope to see you in September. And hopefully, you have the contacts of you have the email of Dr. Onyinye, so you can contact her if you have questions or queries or anything that regarding this presentation or the training coming up in September. Thank you very much. God bless.
Thank you, everyone.
Thanks, everyone. Thank you.
Thank you. Thank you.